Why not? Now we are. So that rounded end is the acromial end right here. You can pretend to make an A. Here's that sternal end. You can pretend to make a T. The acromial end, as we'll see in a second, is going to articulate or make a joint meet up with the acromion of the scapula. So notice the terms acromion, acromial end. Both of them have the same term in it. So that's where anatomy is really nice to us because it has very similar terms meeting up to each other. You then only have to know this conoid tubercle. Notice this rough side right here. This rough side is on the inferior view. So basically the clavicle is going to sit like this on us. It sits like this. The smooth side is superior. The rough side is inferior. So this rough side that we're looking right here, this is that conoid tubercle, small bump. You can kind of see that small bump right there.
Yeah, but it's from anterior or posterior? How?
On the clavicle, it sits a little bit different. Normally, we don't look in a superior inferior view. Usually on all the other bones, it'll be an anterior posterior view. But because the clavicle sits like this and not like this, that would make an anterior and a posterior view. But instead, we have it where it's horizontal, so it sits superior inferior. Yeah. Also, to this direction right here, you can see that anterior is this side, posterior is this side. So on this side of the clavicle, it's posterior, whereas this is anterior. And then this key goes for this one. Now, rights and lefts, one way to, oh, do we have a question come through?
Yeah, when you say since we're looking at the right side clavicle end, so the sternal end of it, would that be towards the shoulder blade?
No, towards the middle. Sternum is in the middle. Yeah. The middle. Yeah, so sternum's in the middle. Acromial end is on the lateral side.
On the lateral side. Okay.
So if we were trying to figure out rights and lefts, then we figure, okay, sternal end towards the sternum. Then if you were to just feel your own clavicle, you could feel it come out, protruding out anteriorly, and then you could feel it kind of like bowing backwards posteriorly. It comes out anteriorly, it bows back posteriorly. Even look right here, anterior, and then it kind of shoots backward right there, right? Now, when you look at this superior view, you're looking at basically what we'll talk about as an anatomical position, your patient's view. This one particular bone is a little bit funkier than the rest of them, so hang with me on it. This is that superior view. This is when we're thinking anatomical position. Sternum is right here. That means that this has to go lateral. So that's going to go to a shoulder. We see that it's on the left side, but because we're thinking, oh, this is my patient, this is actually going to go to their right side, this right shoulder. This acromial end is going to the right shoulder because it's patient view. You're like imagining yourself like in their shoes, right? So this is a right clavicle. Now, let's say that doesn't really work for you. The other thing that you can think of is that you put your palm right here. Imagine, you may have to like twist your head and do it, but you're going to put your palm right here at this sternal end. This only works for the inferior view. You have the conoid tubercle. Imagine it as a snake eye. This snake eye is right here, and the snake mouth is right here. Now, if you look at it and you're seeing, okay, here's the snake eye, and here is the mouth, it's pointing towards the right. Therefore, it is a right clavicle. But like I said, that only works if you're looking at the inferior view. Okay. Questions on that? It is being recorded now. Okay. Rights and lefts, I will say online takes a little bit of practice. Do the practice for it, okay? Over and over, try different views, go online, check out different bones. Don't fall in love with your bones. I will say that right here, right now. Do not fall in love with your bones. What that means is don't look at just one set of bones. Look at many different bones. There's bones on Pinterest. There's bones on Google. There's bones on KenHub. It doesn't matter where you go. There's bones. Every bone looks different with the same kind of structures generally, but one may be a little bit more superior, one may be a little bit more inferior of a structure, more medial, more lateral. It gives you options as to how you look at them. All right. So that's the clavicle. Now we talked about how things articulate together. See how this is the acromial end and this is the acromion? Those two words, they have the same meaning or they sound the same, and therefore they're going to articulate. And right there where you see that line, that's the articulation. This is the acromial clavicular joint. Don't have to know that, but that's at least for you to know in case you do. Let's say that you were to go and dive for a baseball or a softball or a frisbee or whatever the case may be, and you fall down and all of a sudden you're popping your clavicle out of its joint. You're basically knocking this acromial end up. More than likely, you are hurting or putting the acromial clavicular joint out of place. Now, if we're looking at the scapula, there's a few different views of the scapula. There's the anterior view, posterior view, and the lateral view. When you look at the anterior view, you basically are looking at this smooth side right here. If we were to look at the anterior view on a skeleton, we have to take into consideration that basically what we're going to be doing is we're going to be looking through the rib cage. We have to look all the way through the rib cage, through the lungs, through the heart, all of it just to get to this anterior side. And that's that smooth side. The smooth side is what rests on top of these ribs. The smooth side rests on top of the ribs. That's the anterior view that we're looking at. Now the posterior view, this is the view that people are most commonly, or they're most familiar with. That's because we see this structure right here. This structure right here, or right here, that is known as the spine. That tells you automatically posterior. So right now I'm just telling you anterior versus posterior. The view that we have right here on the screen is anterior because it has a smooth surface. This is what rubs up against the ribs. Now the posterior view is going to be this view right here. There's that spine. When you go to the beach and people are in their bathing suits or shirtless or whatever the case may be, and they're moving around and they're moving their arm up, you may see this scapula moving. And when you see it move, this spine may be what you're seeing moving back and forth because it pops out the most. If you look at just the structure right there, it really pops out right here. So that's what you can actually physically see on someone on their back. Okay, so that's that posterior view that we're talking about. Let's go back to the anterior view real quick. I'm going to tell you this one structure for you to just hang tight and then run with me when we get to the posterior. I think it'll make a little more sense. Fossa, shallow depression, right? Here's that fossa. Subscapular. Sub meaning below, scapular referring to the scapula. This is a funky one. I will tell you that right now because it doesn't make much sense. Basically what it's meaning is that it's below the scapula. If we're looking on this posterior view, it's below the scapula, this fossa, like as if I were to try to reach underneath to touch next to the ribs. That's the subscapular. That's what it means. Oh, finger is stuck. There we go. Subscapular fossa has to be smooth without anything else there because when it glides in protraction and retraction, that is what is going to allow for it to glide and not get stuck on something as it moves. So it has to be smooth. Sorry for all the background noise. Okay. Then we have two structures that you can see from this side. We have three. We have this one right here. This is the coracoid process. Coracoid process on the scapula. I'm being really annoying with this and I'm doing it on purpose. Coracoid on the scapula. Both of them have C's in it. So that is a key thing to remember. Really, truly, I'm saying this because of the fact that there's another structure that is very similar in spelling. So you want to make sure you get this right. If you were to put the other one right here, you're going to get it wrong, even though it's only 2 letters off. So coracoid on the scapula. Both of them have C's in it. Cora means raven's beak. And so if we just look at this view, this kind of looks like a beak right here. There's that beak, and then here's that wing. The next structure that we see is this right here, this tall point, acromion. We just talked about it a moment ago with the clavicle having the acromial end, and it meets up with this acromion process or the acromion. Now the acro means tallest point. So acro, like an acrobat, is high up in the sky. And the acro is going to tell us that it's the tallest point of the scapula. And if we were to look right here, this is the tallest point. So that's that acromion right there. You will also see it labeled as acromion process. Now this structure right here is known as the glenoid cavity or fossa. You can use either one. Glenoid cavity or the glenoid fossa. The glenoid cavity, glenoid fossa, we can also see from a lateral view, and I'm going to show you on this one. Here's this view right there. That's basically this structure right here. If we're looking on here, it's right there. It's smooth. It's technically a shallow depression because that's what fossa means. And then here we have the coracoid process and the acromion, because the acromion is the tallest point right there. Now the glenoid cavity is going to help make up the glenohumeral joint. Here we have the glenohumeral joint because we're taking the humerus and the glenoid cavity and combining the two. Anytime you have a joint, it's basically going to tell you where it's from. The two bones or a bone in a structure.
So, Danny, would it be like a socket?
Yes, it's exactly a ball and socket. It has to be smooth right here for this fossa in order to be able to house this head of the humerus. And because that, it allows for our rotation for us to be able to swing our arm all the way around.
Is that where your rotator cuff is, around that?
Your rotator cuff muscles are actually all surrounding here. Yep. And so basically the rotator cuff muscles are going to wrap around trying to keep that, glenohumeral joint in place right there and support it.
So what is the white stuff? It's a kind of tissue. What was it?
This is where we have that articular cartilage here that will sit on top of it. Yeah. So right here, it technically is bone, but we'll also have a little bit of that articular cartilage to soften that joint up. All right, posterior side. Now here's the posterior side again. We see that spine. That's a real critical landmark piece to be able to locate. Can't locate it, that means you're probably on the anterior side. Here's the posterior side again, spine. The spine is a big structure to tell us where the next two structures are. Supra means superior. Spinous is referring to the spine. So supraspinous fossa is a shallow depression that is above the spine. And that's right here. The supraspinous fossa is above the spine, and it's a shallow depression. If we look right here, this is a shallow depression. It's smooth. And that's that supraspinous fossa. Now this goes the same for down here, the infraspinous fossa. It's another shallow depression, infra for inferior to the spine, and it's a fossa. See how that works? It's all telling you exactly where it's at. And then of course too, you have the spine, and then you have the acromion right over here. Now, rights and lefts, how do you tell? My favorite way is to be able to see this view right here, this posterior view that we have. Now, if you look at this posterior view, you are not thinking about patient view because patient view is always in anatomical position. And what side do we look at with anatomical position? What are the characteristics of
We're
anatomical
facing
position?
forward.
Anterior.
There we go, facing forward. So the anterior side, yes. So this is posterior side. So whenever you see something posterior, it's the view that you have, all right? So this spine is right here. Then we know the acromion is going lateral because we don't have this big old bump in the middle of our back. Yeah, we have these tiny little bumps, but it's not this big. That means this acromion has to go lateral, out to the shoulder. Here's the spine going out to a side. This acromion is on the right-hand side. That means this is a right. This is a right scapula. Now, what if you're given an anterior view? What side is this scapula?
The right side.
It is
The-
a right. Good. Yes. Because we don't see the spine, we see the acromion, but to us, it's on the left side. But we remember, ooh, this is anterior. That means we need to think about our patient view. So yes, this is a right. Good. Questions, comments, concerns? Okay, I'm going to go into the humerus then. We're going to keep on moving. Okay, humerus. Come on, there we go. Now the humerus is going to have that head. We just talked about how the head of the humerus has to meet up with that glenoid cavity or that glenoid fossa. So that means that it's going to be medial because this head can't be pointing out here towards the lateral side and make up the joint. It has to be pointing medially to make up that joint. With that being said, there's another structure that can help you figure out if it's medial or lateral. And that's on the distal end is this big old bump right here. This huge bump is known as the medial epicondyle. I do want you to know medial versus lateral epicondyles. The medial epicondyle, take a wild guess as to what this structure is. Like what you would think in before anatomy. What is this structure? What would you call it?
Elbow?
Close. What else is near the elbow?
Your funny bone.
Yes, the funny bone. And guess what? It's on the humerus. It's so funny. Okay, yeah, I know that's terrible, but really, truly, this is your funny bone. This is the funny bone. It's actually not what you hit when you hit something. You're hitting the ulnar nerve that wraps underneath it. But still, this medial epicondyle is the funny bone. So if you were to look at it and you're like, oh, I found the medial epicondyle, it's this big bump that's telling you it's the medial side. That means this head is on the medial side. Bam, you guys already know medial versus lateral. Now, on the lateral side of the head is this bump. What do we say is a bump? What's a term for a bump? A smaller bump.
Tubercle?
There we go. Yep, a tubercle. Okay, there's a bigger tubercle and a lesser tubercle. And therefore, we call it the greater tubercle and the lesser tubercle. So here's that greater tubercle because it's bigger. Here's that lesser tubercle because it's smaller. Okay, so those are the two bumps that you find on the other side of the head. So the head is medial, the greater tubercle is lateral. Then we see this rough patch. What's a rough patch? Someone who hasn't answered yet. What's a rough patch? What's it called?
Tuberosity.
There we go, tuberosity. That's exactly what this is. It's the deltoid tuberosity. Now, The deltoid tuberosity, notice again, it's on the lateral side, and that is because we have a muscle that starts right here and it wraps around and inserts right onto that deltoid tuberosity. Can you guess what that muscle is called? Might be in the name, just maybe.
Deltoid.
Deltoid muscle. There we go. It's the deltoids, the delts, whatever you want to call it. This is when you go to the gym and you do your flies. You're going front, back, side to side. Those are the deltoids working. And so that deltoid is going to wrap around right on this deltoid tuberosity, mid shaft. Okay, now looking at that distal end of the humerus. And notice too, humerus does not have an O in it. It's just you and me. It's just us. All right, humor-us. And we have that medial epicondyle. That's going to be your landmark everywhere you go on the humerus. From there, you're going to have a few fossas and a few condyles. Now, these condyles have very specific names. We said epicondyle means on top of a condyle. So here we have a medial epicondyle. Here's the lateral epicondyle. Notice how small that lateral epicondyle is. Not very big at all. Lateral epicondyle right there. With that being said, those are on top of condyles. Condyles are bumps. Here are some bumps right here. This is the capitulum, supposed to be like a head. This is the trochlea. A trochlea means like a pulley. And so this pulley we'll see in a moment is what helps us flex and extend our elbow. It does it like this. So that trochlea, I like to say the trochlea rather than the medial condyle for a very specific reason, because just like the acromion and the acromial end, it's going to tell us the next structure. So here's the trochlea that looks kind of like a pulley, and here's a capitulum, which is supposed to look like a head. A little bit more proximal to the trochlea is this fossa. Now it's pretty tiny. If we look at this one right here, there's not much to. Here we have the medial epicondyle, here's the trochlea, and then there's this kind of like little fossa right in there. It's not that big, but that is known as the coronoid fossa. Remember how we had a coracoid on the scapula? Well, here we have a coronoid. That's what I'm saying. You got to make sure that you know where they're at. Why we call it the coronoid fossa will be told in just a moment, but it'll make sense. On the anterior side is the coronoid fossa, the smaller fossa. Here's another view of it. Here we have that head, greater tubercle, lesser tubercle. Don't worry about all the other structures. Deltoid tuberosity. Sometimes you can't quite see it from the anterior view, but maybe a little bit more for the posterior view. Again, don't fall in love with your bone. So it depends on which bone it is, but a rough patch is what you're looking for. Medial epicondyle. And then we also have the lateral epicondyle, capitulum, trochlea. Coronoid fossa on the anterior side. Before we move on to the posterior side, is this a right or a left? Based off of your knowledge on anatomical position, is this a right or a left?
Right.
Right.
Good. It's a right. There we go. See, you're catching on just from what we learned. Use that for the rest of it, of just making your educated guesses. Awesome. I'm loving it. All right. I'm going to show you this in just a second. Posterior view. Everything's pretty much the same. Head, greater tubercle. Not going to be able to see the lesser tubercle. Deltoid tuberosity. Remember I said that you'll be able to see it a little bit more on the posterior side sometimes. So deltoid tuberosity, maybe where you see it more. But really, truly, if you think about it, there's nothing else that's in this region. So if it's pointing mid-shaft, go with the deltoid tuberosity. Then if we're looking at the posterior distal end, medial epicondyle, because it shoots right on out. Lateral epicondyle, you can't see the capitulum, but you can see the trochlea right here. Remember how we had the coronoid fossa on the other side and it was really small? Here's the olecranon fossa, massive. It's big right here, big old sucker right there. You will see why it needs to be much larger than the coronoid fossa. Okay, if this is a posterior view, what side is this, right or left?
Left.
Right.
Oh,
Right.
Ooh, we got both.
oh, sorry, right.
So give me your reasons. Why is it a right or a left?
Because it's a right because we're looking at the posterior.
There we
The
go.
back. Okay.
Good, good, good. What are your landmark structures?
The head to me.
Medial and the sternal, lateral.
So the medial side, okay, or the medial epicondyle. So the sternum is going to be medial, so it's pointing towards the sternum. If that's what you're making your kind of like your landmark piece of what is most medial, yeah, you could do that. Okay, so this is a right because here we're looking at posterior view. Here's the medial, and therefore this is a right. Now, let's talk real quick about the radius and the ulna, and then I'll talk about the joint, the elbow joint. How this saved it this way, I don't know. So let me get my eraser real quick. Is it design or is it draw? I never remember. Draw, there we go. Okay. There. Now, we are looking at the anterior view of our radius and our ulna. We are now on the bones of our forearm, okay, the antebrachial region, the forearm. If we were to look in here, we have a few structures that really stand out. Now, first off, what I like to show is this one right here. It's kind of like a slide. This right here has this curve to it. In fact, if I were to bring out the radius and the ulna, here is this slide that we're talking about, kind of a U shape. One of those has a U in the name. What do you know? It's going to be the one that has a U shape to it. So the ulna is the one with the U shape here on the proximal side. That U shape, that little slide that we see, that is known as the trochlear notch. We just learned a structure. What was the structure? That sounds like it.
Trochlea.
Yeah, there we go. So guess what? The trochlea and the trochlear notch are going to meet up next to each other. They're going to articulate. So the trochlear notch is going to go on the trochlea. There is another structure that we should point out. This one right here. And I'm going to just do an arrow to it on this side so you can see the pointiness. That right there. It is also a raven's beak. What did we say was the term for a raven's beak?
Coro.
Coronoid?
Cora, yeah. And so for here, it's the coronoid. The coronoid process on the ulna. Coronoid, and again, coronoid, not coracoid with the AC. This is coronoid, O-N, on the ulna, an N in there. Coronoid process. So that coronoid process is going to be able to go into the coronoid fossa on the humerus. Oh, I just love anatomy, how it just goes together so nicely. See, it goes like this. And that pointy part right here, we don't have to worry about it hurting or pinching or anything because it just sits so nicely when we flex our elbow and goes right into that fossa. Isn't that cool? Man, we are just created so perfectly. All right. Now, the next one is this big old structure back here. This big hunker. That is known as the olecranon. You'll also see it as the olecranon process. Now, the olecranon, you can actually feel. What do we think this structure is? Give it a shot for where the location is. What do
Is
you
it
think this is?
Like the
Funny bone?
elbow? The elbow?
Elbow.
Now it's the elbow. Yep. Now the olecranon process is the elbow, whereas the medial epicondyle was the funny bone. So here we have the elbow. You can feel it right now, that big old thing. Now feel it, and when it's flexed, when your elbow is flexed, you can feel that thing sticking out, right? Now follow it. Keep your hand on it and start to extend. Where does it go? It like disappears, and then it makes it where it's like even with the humerus, right? Man, this is because, what do you know? That olecranon process. Look at this. Oh, it just fits so magically in there. And it's going to extend like that, and then it just lines right on up. That's why it's so big, to be able to take in the olecranon process. Gotta love anatomy. Okay,
Or fossa, right?
the olecranon process goes into the olecranon fossa. Yep. Okay, I'm gonna stick to this proximal end of the radius and the ulna real quick to then talk about some of the structures on the radius before going distal end on the ulna.
Is the olecranon process the same as the olecranon?
Yes. You can see it
Oh.
interchangeably. So when you're taking your exam or your quiz, you could just put olecranon. That's totally fine. But just don't be alarmed if you see process elsewhere.
Okay, so that's the elbow?
Yes. Mm-hmm.
Oh, okay.
Olecranon process is the elbow. Yeah. Okay. Now, when I was terrible at math. I'm going to be honest. I hated math. Still do. That's why I have a partner who's an engineer. I just give him all the math problems. When I think of math or anything revolving that, for whatever reason, I think of radius and then I think of circle. And by golly, we got a radius that is a circle here. And that is what's going to help you remember that this radius, I know it's not the whole entire thing. You have to have the diameter to have the full circle, but roll with me here. The radius is the one that has the circular head. So right here, if we're looking, here's that circular head. That's going to be the radius. And of course, too, we already said this is a U shape, so it's an ulna, but that is the head of the radius. Head of the radius. And you could just put head. You don't have to put head of radius. You can if you want. Next structure, bumpy patch. What's a bumpy patch or a rough patch?
Tuberosity.
Yes,
Tuberosity.
tuberosity.
Yeah.
No worries at all, Leda. So a tuberosity, that's this right here. And we can see it right there. Now, this one is known as the radial tuberosity. Radial tuberosity, which it's on the radius, so that makes sense. But actually, the radial tuberosity does have muscles that are going to attach to it that you may see it known as the bicipital tuberosity. That can be another term for it because what do we have right here? Our biceps, and those are going to insert right on that radial tuberosity to help us be able to flex and extend. More of the flexion. We'll get into all how those muscles work in a few weeks. So that's that radial tuberosity. Now, if we go to the distal end of the radius and the ulna, now we're looking at these pointy parts. Remember how I said a pointy part or a styloid sounds like a stylus, and that stylus is like a pen. So these pointy parts are essentially the pens of the radius and the ulna. It's the styloid processes. Styloid processes, the pointy parts on the distal end of the radius and the ulna.
Can we put pants and it has to be the correct word?
You have to put the right word. That would be awesome if we could, but nope, need the styloid process.
Danny, can you share what you shared in the Tuesday class with the thumbs up? That helped me remember radius and, okay, sorry.
Yep. No, I'm glad that you bring that up. That's my next move. Okay, so when do we know on what side is the radius and what side is the ulna? Well, this is where you're going to think of your really rad friend. And whenever you come across a really rad person or a rad friend, you give them a thumbs up. And that thumbs up is going to tell us, ooh, radius is rad and it's on the thumb side. So if we're looking at anatomical positioning, thumb is lateral, it's rad, so radius is on the lateral side. Yes, indeed. That's probably one of my favorite. I love that one.
So Danny, so then if we think of ulna, can we say like pinky side, or that would be?
You could, yeah, ulna. It's going to be on the pinky side, the medial side. Yep.
Okay.
I'm so glad that you like that one, Crystal. Like I said, it's my favorite. It's so fun to say it. Nerdy, but hey, it works.
Can you explain that again? So radial's on the lateral side and ulna is on the...
Radius is on the lateral side because it's thumb side. And when we think of anatomical position, our thumbs are on the lateral side because we have palms forward. So the thumb is lateral and therefore the radius is rad on the thumb side. Thumbs up.
Okay.
Okay.
So did Crystal go to this class Tuesday and Thursday? I keep forgetting. What was on Tuesday then?
Tuesday was lab as well, but because we had both exams and people's brains were pretty much fried.
Gotcha. Okay. I'm like, did I miss something? Okay, I'm following now.
Yeah.
Sorry. All right.
Yeah.
Sorry.
No, I'm glad that you all are taking advantage of that. And also to Thursday, I want to extend that if you do have the opportunity to go to Tuesday and you want to, feel free to be able to see this stuff twice. I am A-okay with it. A-okay with it. Let's see. I just want to show the posterior side of the radius and the ulna just so you can see kind of the view of it. Not much of a difference. The biggest thing on the posterior side that you would find is this right here, that olecranon process. It's just much more apparent. And we know that that's posterior view because we don't see the semilunar notch. Now, just from your own knowledge, what side is this? Right or left?
Left.
Okay, so tell me why it's left.
Because your thumb is on the radius and yeah.
Okay, so thumb's radius, good. But
So
then
But that's the back, right?
On the right side.
palm, if the palm is facing posterior or anterior.
so at
Lateral.
this point, because we see the olecranon process, what side is the elbow on? Anterior or posterior?
Posterior.
Posterior.
Posterior. So then is
Okay.
this patient view or your view?
Our view.
Our
Our
view.
view. Oh,
Mhm.
our
So
view.
then
Sorry.
what side is this?
Right.
There we go. Yeah. I'm so glad you guys are getting this. And see, it is totally fine to make, these processes kind of come together. Why is it freezing up on me? No. Come on, PowerPoint, really?
So when you ask us on a test, what side is this on? Are you asking us in general or how the picture looks to us on the screen?
How the picture looks on the screen. You'll have a random image of a radius and ulna, and I'll ask, is this, what is the name of this bone and what side is it?
Okay.
And then at that point in time, you would say, this is a radius, or this is an ulna, or a radius and ulna, and it's a right side. Or maybe I just ask you, what side is it?
Okay, thank you.
Yeah, no problem. Come on. Oh, this is going to be sad. Okay, from here, what questions do we have since PowerPoint is not wanting to be on our friend list either?
So on the test, you're not going to ask if it's anterior or posterior. You're just going to ask if it's right and left and what the bonus.
Yep, more than likely. Yep.
Okay, thank you.
It's more of you having to know whether it's a anterior or posterior view based off of the structures.
Got it.
Yeah.
Thank you.
You're welcome. Oh,
I
goodness.
think maybe if we look at the picture upside down and compare with our arm, it'll kind of give us the idea of what side it is.
You know, okay, so certain people can totally do that, others can't. Like there's some people who can like grab the image in their mind and like place it on their own body and figure it out. Others can't. So if you're able to do that and it works for you, do it. But that doesn't always work for everyone else. So I don't want to confuse others for that, to get into that and then have it not work for them. Okay, hold on. I gotta restart this PowerPoint. Jeez Louise. You know, 2021 is really testing us. That is for sure. It's asking me to restart. I'm hoping this restart of the PowerPoint works really quick. If it doesn't, I do have a backup. I just got to log on to it. Which, for the heck of it, I might just go and do that right now. Everyone tell me something that has stood out to them right now that they will remember. Something that helps. And then you got to try to figure out something else that someone hasn't mentioned. Ready, set, go.
That the thumb is lateral, which is the radius.
There we go. Next one.
The ulna has a U.
There we go. Nice. Next one.
You have two styloid processes, and they're on the ulna and the radius.
Very good. Next.
The process end has a T.
Okay, one more time.
The sternal end, it looks like a T.
Perfect. Next one.
The process matches the name of the part of the bone.
There we go. Okay, it's like a bump, and then you're seeing how it matches with the fossas. Nice. Next.
Epi means on the top.
There we go. Next one.
Acromion. That one's like an acrobat, tallest point.
There we go. Good, good, good. Give me two more.
Tuberosity means rough patch.
Yes.
The spine is always on the posterior view.
There we go. Loving it. See, firing away. You all still have it. Rocking and rolling. All right, my PowerPoint's working again. Let's get back into it. Okie dokie. So now, just so that you can see up close, this is what that radius and that ulna. I'm going to have to start moving forward to get towards that, those lower appendicular bones are. But essentially, this is how that coronoid fossa or process is going to go into the coronoid process. Coronoid process goes into the coronoid fossa right here. And that is going to be when we flex and extend. The olecranon process right here is going to come out of that olecranon fossa and then go back into it when we extend our elbow. So I just wanted to show you kind of how it sits in there and how it goes. There's just that little fossa for that coronoid process right there. Okay, let's go on to the hand. Now, the hand is going to be very similar to the feet. So I want you to really pay attention here in case we can only cover the first part of the foot, because it's essentially the same thing, just one difference in the name, and then that's it. The first part right here are our carpal bones. We drive a car with our hand. Therefore, right here are our carpal bones. Then we have metacarpals. Metacarpals. The metacarpals you can feel on the back of your palm. Feel it. You can feel those bones, those long bones right here. Those are your metacarpals. Again, carpals and metacarpals, we drive with our hands. We drive a car with our hands. Then we have phalanges. Now, phalanges are basically our fingers, and we have a bunch of small bones in those phalanges. If you were to look your hand, now close the hand. When you slowly start to open, you can see that there's different joints. Like we have one bone here, one bone here, one bone there. So we have 3 bones in the one finger. That goes for all of our 2 through 5 fingers. But if you look on the palm side, you can see lines. Those lines are indicating joints. Now those joints are right there. But on the thumb, there's only 1 line. And that's because we only have 2 bones right there.
I was looking for the other one.
Oh, sorry. Right here is only 1 line. So then you only get 2 bones, 1 right here and 1 right here. There we go. All of those are individual phalanges. Now, phalanges is plural. Phalanx is singular. So phalanges is plural. And isn't that cool with the lines? It's like, it's telling us already what's going on there. Phalanges is plural. Phalanx is singular. We have a proximal row and a distal row, as well as a middle row. Now notice, proximal row is going to be touching or articulating with those metacarpals. Then we have our distal row, which is the furthest most. Now remember how on the thumb we only have 2 fingers in there, or 2 phalanges in there? We don't have the middle one, but we have the distal and the proximal, the distal and the proximal. Here we just have the middle, 2 through 5. So you have the proximal, middle, distal phalanges. This would be your proximal phalanx 3. Why? Why is it proximal phalanx 3?
It's the third finger.
Comes from the 3rd finger. And that's exactly it. Our thumb is 1, index is 2, middle is 3, ring is 4, pinky is 5. So whenever you label these, you want to make sure that you're labeling the number as well as what row it is. So we have middle phalanx 4, distal phalanx 2, distal phalanx 1. It does not change because of the fact that the thumb only has 2. It still originates from the 1, okay? So those are the phalanges, the metacarpals, same thing. Metacarpal 5, metacarpal 4, 3, 2, and 1. You want to name those. Then we have our carpal bones. Now these carpal bones are right here. We're going to go proximal row, and then we're going to distal row. Proximal row, you always start thumb side. We're going to go thumb side, and then we're going to go lateral, from lateral to medial, and then we're going to go distal row, lateral to medial.
So Danny?
Yeah.
Sorry, I might have to ask you again. So the 2, 3, 4, and 5. So I know the thumb's going to be different than the fingers. So would they all be named proximal phalanx? 2 and phalanx 3, 4, and 5, they will all be the same?
Yeah, proximal phalanx 2, proximal phalanx 3, proximal phalanx 4, proximal phalanx 5, because it's on the first row that's articulating with the metacarpals.
Oh, okay.
And then middle phalanx 2, middle phalanx 3, middle phalanx 4, 5. And then distal, same thing.
Okay, cool. Thank you.
Yeah, you're welcome. Okay. For the carpal bones, it is the scaphoid. That basically means like a little boat, little dinger boat. Lunate is like a half moon. We can't see it, but if you were to disarticulate them, it looks like a half moon. Then we have triquetrum and pisiform. Those are 2 separate bones. The pisiform does sit on top of the triquetrum. We finished our first row, our proximal row. We got to come back to thumb side. We have trapezium.
Is pisiform the thing that you see on your?
Not that side. That's the styloid process. These are styloid processes. But on this side, the reason why we have the pisiform is so that way there's a hole that goes through here. So this is going to have a ligament that goes through. This is where our carpal tunnel is. That's to allow for blood vessels and nerves to pass through. So it rises up from the the trapezium, see how there's that bump on the trapezium, and the pisiform creates a channel or a canal there. So trapezium under the thumb, that could be one way to remember it. Trapezoid, capitate, once again, you decapitate someone, you take their head off. It's long like that. And then hamate. Hamate means hook. You can actually grab the hamate and hold it up. Right here. There it is. I could hold it up just by that hamate, that hook. So it's a little hook that comes right there. How in the world are you going to remember these in order? Well, if you have kids, maybe put this on like your headphones or muted or get them out of the room, whatever the case may be. But here it goes. Here's a mnemonic. Some lovers try positions that they can't handle. Okay. So that is one way. It is the infamous way of remembering the carpal bones. You say that to anyone who's been through anatomy, they're going to remember that one.
Can you say that again?
Yes. Some lovers try positions that they can't handle. And that's going to stand for each of the first letter of all of those terms.
And that's including both sides.
Yep, both sides if you were to look at it. Okay. I know I'm moving quick, but you do have the recording, so you can go back through and check it out, okay? All righty, here we go. We're going on to the lower appendicular. Now, I do want to say real quick before we get on to the lower appendicular, there is a single bone. And then we also have the, if we were to have the bones articulated together. Remember today how we talked about how there's 206 bones in an adult, and then as an infant you have 300. Well, that's because one of them is the innominate bone that we're going to go over. The pelvis or the pelvic girdle is only when you have, the pelvic girdle is only when you have the right and the left innominate bone. But the pelvis is when you have all of it, the sacrum, the coccyx, and both innominate bones. So this is the pelvis all together. The pelvic girdle is only the right and the left innominate bones. So when I put a bone up, and let's say that I put this bone up, it would be incorrect if you put innominate, or it would be incorrect if you put pelvis or pelvic girdle, because this is not the pelvic girdle and it's not the pelvis, because the pelvis needs all four of those bones, two innominate bones, sacrum and coccyx. The pelvic girdle needs both right and left innominate bone. So this is a innominate bone or os coxae, either or. Okay. First thing that I always look for is this structure right here. Oh, do we have someone coming through on a question? Nope. Okay, just some chatter in the back. That works. So the first thing that I always look for is this structure right here, this big old circle. This is known as the acetabulum. The acetabulum basically means vinegar cup. The acetabulum is where the femur is going to articulate with. So this is the acetabulum right here, and the femur, getting way too excited. The acetabulum is right here. I hope I didn't break it. And that's where the head of the femur is going to go into. That's what makes up our hip joint. That acetabulum is vinegar cup. This is going to tell you that it's lateral, because if we had this being medial, let's say that it was like in the going medial, then the femur wouldn't be able to go in here. So it has to be lateral in order for the femur to be here, just like the humerus and the ulna, or the humerus and the scapula, because now we need that femur to be able to rotate around. Okay, and be able to abduct and adduct and the whole works. So that in that acetabulum is your key part to say that is lateral.
Is that the left side?
This would be a right side. This would be a right side. So this is looking at the person right here on this right side. This image doesn't really help because it looks like it goes clear across to the other side, but lateral. And this is the anterior side over here. This is posterior. That acetabulum is the first thing that you want to look for. The next thing is going to be this right here, this hole. That's the obturator foramen. Obturator foramen, not obturator with a P, it's a B, obturator. That's going to be inferior. So if we're looking, this is inferior, this is superior. Obturator foramen is inferior of the acetabulum and inferior on the bone. That'll help you tell that this is going to be superior up here. Now there's a few structures that are going to go just like, we're going to go in order from here. Okay. And I'm going to start with at the top on the ilium. When we look at these, we're basically going to, do anterior side and wrapping around. So we're going to start on this side. We're going to wrap all the way around here. This first one is just above the acetabulum right here. It's on the anterior side. But if we refer it to this view right here or this structure, that is on the anterior side as well. But this one is above this one. So therefore, this is the anterior superior. This is anterior inferior, just because of the location of where it's at. You have technically, Lily, until Saturday to be able to take it because it only opens up tomorrow. It just opens up tomorrow. So I know it's a lot, but I would say just go over the individual videos would probably be the best thing at this point. Anterior, superior, anterior, inferior. Now this is part of the ilium, which is the bone, and the bone basically is this portion up, is the ilium. So that's why we're saying anterior, superior, or anterior, inferior, iliac, because it's referring to the ilium. And then it's a spine, because it's a little bump, a little tiny bump. It's smaller than the tubercle. So it's a spine. So anterior, inferior spine, iliac spine, anterior, superior, iliac spine. Now, after that, we see this big old ridge right here. That big old ridge is the iliac crest. It is like a mountain ridge. It's the crest. You can actually feel it. You can palpate on your side and you can feel all the way from the front to the back. You can feel that iliac crest. Once you go to the posterior side, you see this spine, and then you see this spine. Same thing applies. Posterior, superior, iliac spine, because it's on the posterior and it's above this right here. It's a spine and it's on the ilium. So this is a posterior, superior, iliac spine, posterior, inferior, iliac spine. Good with those? Does that make sense? It's just a long name, but it's really direct on what we're talking about. Last structure on the ilium, because remember that the innominate bone is made up of 3 bones. This right here. This is known as the greater sciatic notch. What do you think passes through here, just from your common knowledge?
Sciatic nerve.
Yeah, there we go. Sciatic nerve is going to go right through here. It's a big nerve, so it needs some space to go through there. There's the greater sciatic notch. Greater sciatic notch will lead you directly to this structure right there. That structure is now, we're no longer, bear me with all of these like lines and stuff. Here is the ilium, okay? There's the ilium. There's the ilium. This is going to be the ischium over here. And then this is going to be the pubis over here. Those are the 3 bones. Now, because of the fact that we are looking at, oh, I've had a few of it. I'll have to tell you about it. It has not been fun. That sciatic nerve, it has been agitated quite a bit already. I'm hoping it settles down. only halfway through with the pregnancy. So just like on all the other bumps that we've seen, they're spines, but because now we're in a different region or a different bone, this is now the ischial spine. So this right here is the ischial spine. Greater sciatic notch leads us right to that ischial spine. Let me erase it so you can see it. Do we see that ischial spine? The ischial spine is then going to point us right to this right here. Remember, anytime you have a greater, you have a lesser. So that's the lesser sciatic notch right there, the lesser sciatic notch. You can literally follow your list on your lab manual all the way around. Each of these structures point to each other. That's why I'm sharing it in this perspective. The next part, it's a rough patch all through here, and it also extends into there, but it's a rough patch. Name for rough patch?
Tuberosity.
Tuberosity. Good, good, good. Now we're in the ischium, and so therefore it is the ischial tuberosity. That is the ischial tuberosity. This is your sit bone. You know when you sit on the ground way too long, or my cyclists out there, when you sit on the bike and it starts going numb right down there, you're like, ooh, that is really uncomfortable. Or a spin class and it starts getting really agitated. That's your sit bone. That's what you're sitting on, is that ischial tuberosity. Last thing is going to be technically on the side of this right here. This is a pubic tubercle, but when we have the two articulating together, it's the pubic symphysis. Pubic symphysis. Now you can basically follow the exact same thing on the medial view. And just for time's sake, I'm not going to go through it, but on the medial view, you can see the exact same thing, okay? The one thing that you want to make sure, there is no acetabulum right here. So that's telling you this is not the lateral view, this is the medial view instead. So this is the medial view. So then what bone is that, or what side is this, right or left? If this is the medial view and you're looking at it from the side.
It's the
Left.
right.
It's the right. Here's the anterior side. Here's the posterior side. This is superior. This is inferior.
Oh, yeah.
And then we don't see the acetabulum to have the innominate or the innominate bone meet up with the femur. There we go. So then let me ask you on this one, what side is this?
Also right.
Is that the right?
You're right.
Also right. You got it. Yep, yep, yep.
Yeah.
Okay. Y'all are pros at this. You got it down like it's nothing. In the PowerPoint, there's this really cool differences of male versus female. I wish I had time to be able to talk to you about all of it. Basically, it's just a few structures. Biggest one being at the fact that this outlet and inlet have to be wider in order for the fetus to be able to pass through. Could you imagine? Childbirth is already, as I've heard, supposed to be really painful. And then could you imagine if it was smaller? Like, what the heck? So that's why, I mean, just look right here. That's a huge difference. Hence also to why there is the common theme that females have wider hips. Also, when females have smaller hips or a smaller inlet, then it does create some challenges for childbirth. Here's another view of those differences. So feel free to check those out if you'd like. I think I'll refer to them in lecture more. So that's something I'm just pointing out right now. You may want to review for lecture. Hint, hint. Okay, here's the femur. Now the femur is the biggest, heaviest, longest bone of your body. It is the bone of the thigh, the bone of the thigh. Now this one is not going to break unless you have some kind of crazy accident or if you are malnutritioned. That's the only time that this one will break, more than likely.
So Danny, is this the bone that connects to the hip?
Yeah, the innominate
Okay.
bone. This is the one that goes into that. So the head is going to go right into that innominate bone. And that's basically this right here, that head right there. Good, good, good. Okay, let's start with the basics. We got the head and we have the neck. Just like our head, it's bigger up on top, and then our neck is a little bit smaller. Here we have the head, here we have the neck, right? Makes sense. Okay, next to the head though, on the medial side, because we already determined any head is going to go towards the medial side because it has to articulate with some kind of joint. So this is going to be medial. This will be lateral. Now on the head, there's this little divot. It's not very big. If we look right here, you can kind of see there's that divot on the inside right there. That divot is known as the fovea capitis. Fovea capitis. Now the fovea capitis is basically where we have ligaments and tendons being able to secure our joint, the acetabulofemoral, acetabule for acetabulum and femoral for the femur, the acetabulofemoral joint or the hip joint. That's what keeps it in place. So kind of like how the rotator cuff muscles wrap around the shoulder, this is where we get those joints for those ligaments to wrap around and keep this joint to be solid and stable. So that's what the fovea capitis is for. Remember how we had a structure on the humerus. I want to quiz your memory right now. On the humerus, no.
One of those right here.
Humerus is up here. Yes.
No, one of those phobia things.
No. There's not a phobia. I'll have to try to think of one like that, but phobia is, I think it's the only phobia.
Okay.
Yeah. I think it's the only phobia in the body, but I could be wrong. Okay, on the humerus, now we're talking about the thigh right here, the femur, but on the humerus, we had the head, and then what did we have on the lateral side of the head? Do we remember what that structure was? On the lateral side of the head of the humerus.
The radius? No.
That's down here.
Greater tubercle?
Greater tubercle. There we go. Okay, so this same thing is going to happen, but this is much bigger than a tubercle. So it's known as the greater trochanter. Greater trochanter. So there's a greater trochanter. If you have a greater, you have a lesser. Here's that lesser trochanter. Greater trochanter, lesser trochanter.
So then the greater tubercle will be the top here.
It'll be on the humerus lateral side, just like the greater trochanter will be on the proximal side of the femur, but on the lateral side. Yeah.
Okay.
Okay, going down the list, we already did the head, we already did the neck, the shaft, that's the main part of it. That's this big old diaphysis part, what we talked about today. And then we have down at the distal end, patellar surface. Remember, we're talking about that articular cartilage today. Patellar surface is right here. That's because we have the patella that sits right on top of it. So it has to have that articular cartilage there in order for that patellar surface to be able to, or that patella to move on that patellar surface. So the patellar surface has the patella on it. And as you'll see in your list, it's a sesamoid bone, the patella.
So would that be the knee?
The kneecap, the patella, yes. Mm-hmm. There we go. Okay. Then the last two are the lateral and the medial condyles. Big bumps. You can see it from the anterior side, but I'm going to show you the posterior side because it's so much bigger on that side. But I still want you to know it on this side. Medial condyle, because we have, if it'll go, we have the head on this side, right? We already distinguished that this was the medial side. And then this bump over here is on the lateral side, and it's a condyle. Again, it doesn't look like it on this view of how big it is, but they are on the opposite side. So before we go to the posterior, what side? Right or left?
Right.
Yeah?
Right.
Right.
Yeah, I was just quizzing you. Trying to make you sweat a little bit. Yes, it's a right. There we go. Here we see on another view, don't fall in love with your bone. You want to make sure that you have the head, the neck, the fovea capitis right there in the middle. Greater trochanter, lesser trochanter, medial condyle, lateral condyle, patellar surface right there. I'm going to show you a lateral view and actually a medial view and inferior view. This is where that condyle is, another condyle. This is as if we had like us operating on someone's knee, and we have basically the femur and the tibia and the fibula away from each other, and they're laying on the table. So this is that medial condyle, lateral condyle. Here's that fovea capitis. Study guides for the lecture is available to you. And then again, there aren't any study guides here for lecture or for lab, but you do have the PowerPoints you can go off of with your lab manual.
Is the fossa then in the knee where the two ligaments line, like the ACL, the center?
In the intercondylar fossa, there's a space that then has like the MCL and the ACL, or the PCL and the ACL. Yeah. Those are going to go attach more to the condyles, actually. Okay. But yes, it's in that general region. Okay, remember how I said the condyles were way bigger on the posterior side? Same with the trochanters. We see a big old greater trochanter on this side, lesser trochanter on this side, big old lateral condyle, big old medial condyle. Okay, just much larger on the posterior side. So right or left?
Right. Right. It's just the back of it.
Mm-hmm. Yep. Right. You got it. Here is the patella, just so that you're aware. The apex, or this pointy part, is basically going to be pointing towards the leg or towards the tibia and the fibula, in case you're trying to figure out like location wise as to where it's looking. So this is going to be femur side, this base, and then the apex is the tibia and the fibula side. This is essentially how it's going to look right there. Femur, tibia, and fibula right next to each other with the patella on top.
Question.
We're almost done actually, so hang in there, y'all. Okay. Whew. Now
somebody's got a question, Danny.
Oh yeah, it's not coming through. What's up?
Did we cover the linea aspera?
No, we didn't. I missed that one. Thanks for calling that out. Linea aspera is on the posterior side. I was really surprised too. I was thinking like, wow, why didn't we talk about that one? It wasn't on the list.
It's only posterior, right?
What's that?
It's only posterior?
Only posterior, yes. So the shaft is the whole region, anterior and posterior, but the linea aspera, linea for line, is right there on the posterior side. And you can see it pretty much going all the way down. It starts way up here near that greater trochanter. It does have actually different names to it, but don't worry about it at this point in time because you don't need to know those other structures. And I'm really bummed because this is my favorite structure right here. It's the gluteal tuberosity, where the glutes, the big old booty, is going to attach to right there. But that's okay. I won't quiz you on that one. So that's the linea aspera right there on the posterior side. Okay, down to the tibia and the fibula. Which one is which? Well, the tibia is the weight-bearing bone. This is the biggest bone in the leg. So you have the bigger bone and then you have the smaller bone. Another way to remember tibia and fibula is that you tell a little fib. and the fibula is little. So that's one way to remember it. The other way to remember as to positioning is that the fibula, it's little, it's a little fib, but it also has an L in the name, and therefore the L stands for lateral on the fibula. So the fibula is lateral and the tibia is more medial, okay? Now, just like the femur, the tibia also has condyles. And it's great because both of these condyles are going to actually articulate together. So the medial condyle of the femur and the medial condyle of the tibia are going to meet up together. Same thing on the lateral side. Of course, there's menisci that are in between it, but still it's going to be there. So this is the medial condyle. Here's the lateral condyle. And we know that because fibula is on the lateral side. And therefore, that means that this structure over here on the tibia has to be the lateral condyle. Now, in between the condyles, right here, is this kind of ridge that looks like this. It is known as the intercondylar eminence. Inter for between, condylar for between the condyles, and an eminence is just kind of like where it protrudes up.
Isn't that little piece that goes into that other one that you guys were talking about, the ACL or whatever?
Yeah. You're going to have some attachment to those as well. Yep.
Would that be the cartilage then?
So it's not, there will be articular cartilage right here as it pops up. Yes, because we have to have that attachment point to it. Yeah. So then we have the tibial tuberosity. And I should say too, the intercondylar eminence, you can see partially from the anterior side. It's much better from the posterior side though. Now the tibial tuberosity, rough patch tuberosity, go ahead and feel below the patella. You can feel it right now. And that rough patch or that big bump with the roughness, that's your tibial tuberosity. Cool thing about this one is that the muscle that's right here on the femur, the main one, the rectus femoris, is going to wrap around and then insert right there on the patella to then have the ligament of the patella wrap on and touch the tibial tuberosity. I'll explain more when we get to the muscles, but it's probably the coolest ligament tendon continuation that there is. That quadricep tendon encapsulates the patella, and then it turns to ligament to attach to right here.
So
what's
so
that?
you're saying that it's not a muscle though that is attaching there, then it's more the ligament or both?
So it never stops. Usually
Okay.
it like goes from a muscle to a tendon and then on the bone and it stops. This one goes from muscle, tendon, because that's what attaches to the bone, a muscle and a bone together. And then it encapsulates that patella, and then it just changes to be a ligament because now it's on a bone to attach to the other bone.
Okay.
So it's just a continuation of it, which is really neat. You don't find that elsewhere in the body.
They use my patella to make a new ACL.
Oh, okay. Very cool. How interesting. Because usually you hear about the hamstrings being used. So that's really cool that they use the patella.
It's been a while ago. They probably don't like using it.
All good. You try things new all the time. That's really neat. You can say something that isn't very often done. Okay, so then from there, we have the anterior crest. My soccer players, this is what we wear shin guards for. Or if you were like me, I used to just stuff cardboard in there and not wear them at all because I absolutely hated shin guards for whatever reason. But if you got kicked right along this line, it wasn't very pleasant. And if you kept getting kicked there, it started chipping away, which isn't very good either. So that's what the shin guards were meant for, to be along that anterior crest. You may also see it labeled as anterior border or anterior tibial crest. So just as a heads up, you might see some variations to that. Last thing on the tibia is going to be this part right down here. This right here is known as a malleolus. And that comes from the term of a hammer. And so the medial malleolus, because we said that over here on this side is medial because we have the fibula on the lateral side. So that's that medial malleolus. Now on the fibula, because we have a medial, we have to have our lateral, and that's the lateral malleolus. So the distal end of the fibula is the lateral malleolus. And then the proximal end of the fibula, that's right there, that's the head. Let me show you posterior so you can kind of see the intercondylar eminence. See how it pops up here in the middle of the lateral condyle and the medial condyle? We know lateral condyle because the fibula being on this side. Notice here, again, tibiofibular joint tells you exactly where it's at, the joint of where the bones articulate. And then again, we have the lateral malleolus and medial malleolus. How are we feeling with so far the lower appendicular?
I think the hip's the trickiest.
Yeah, for sure. The hip is the trickiest just in one, the way that it looks way different than any of the other ones. And then there's just a lot more structures on it. So then is this a right or a left right here?
Right.
Yep, there we go. It's a right. We have the fibula on the lateral side, and then we have the tibia on the medial side, and it's posterior. Don't get comfortable with it all being the right. Don't think like, oh, these are the images. I'm going to go into the quiz. It's just going to be a right. If you were to put a right on the quiz and it ended up being a left, you'd get half credit as long as you named the bone.
It's just because I see the medial, and every time I see the medial, I put my orientation to the middle, medial to the middle.
There you go. Perfect. Good, good, good. Because that's what you should do. Medial, middle. I love it. There we go. Okay. The last grouping. And this one, hopefully too, it'll go a little bit easier because it's very similar to the hand. We already talked about a lot of these. But difference is that all of these bones right here, these are tarsal bones. Tarsal bones. Because we walk on tar. So the tarsal bones are in the feet because we walk on tar, and the carpal bones are in our hand because we drive a car with our hands. That is one way to remember the difference between those. So these are all your tarsal bones, which then means that these right here, what are these going to be called?
Metatarsal.
Metatarsal.
Yeah, good. Metatarsals, because of the fact that it's like our metacarpals. It's still that in between the tarsals and the phalanges. And so it's that metatarsals because we're stepping on tar again. And then all of these are the phalanges. Same thing applies. You have the proximal row. You have the middle row for digits 2 through 5, and then distal row for all 5 fingers or all 5 toes. Okay. Same naming scheme is going to happen. Now, one thing I should point out is that on especially the pinky toe, the middle phalanx and the distal phalanx does have a tendency to fuse together, especially if it's a really like stubby short toe. So you may or may not see much of our like differences in joints there, just because of the fact that they're so tiny and they're usually fused together. But still, it still applies in a normal condition that it would be a distal phalanx 5, middle phalanx 5, proximal phalanx 5. Okay, proximal phalanx 1, distal phalanx 1. Right here, what would this be?
Proximal.
What's that?
Metatarsal 2.
Tarsal 2.
Yeah, you got it. What about this one right here?
Proximal 3.
Proximal phalanx 3, yes. What about this row?
Distal.
Distal.
The
Oh, no, that's middle.
middle phalanx?
Middle phalanges.
Phalanges. Okay.
Middle phalanges. Yep. Okay, good. You guys are getting it. All right, let's go over those tarsal bones, and that's it. All right, tarsal bones. Now, there are 7 of these, whereas there were 8 of the carpal bones. First, the 2 biggest tarsal bones is this one right here, and then this one that's like underneath it right there. This one up here has this really smooth surface. We've already kind of talked about how it has that like whitish color, and that whitish color we discovered today was that articular cartilage. So that means that something has to articulate there. That means that another bone has to be there. Sure enough, the tibia goes there. And I like to remember this as the 2 T's. The talus is the tarsal bone and the tibia goes there. So this is the talus bone right here. Talus bone is right there because the talus and the tibia articulate together. The talus and the tibia.
What about the fibula? It doesn't land.
It just kind of floats there, to be honest. Like it'll be there, but you can break it and dislocate it, and it's not going to do much to it. Like I dislocated and broke my fibula, and it only hurt because I dislocated it out of the joint with the tibia, but it didn't do anything in regards to like me standing on it because of the fact that the tibia is the weight bearing one. That's the one that sits directly on top of this talus right here.
So would that be the ankle part of it, or is that the ankle's more away from it?
So the ankle, it's kind of funny that you say that. The malleolus, the medial and the malleolus, the lateral malleolus, those are your ankle bones. So when you feel your ankle and you have that bump that's kind of hanging out on both sides, those are the medial and lateral malleolus.
Oh, okay.
But just below that is the ankle joint.
Okay.
Yeah.
Okay, cool.
And that's where these 2 bones would articulate. Okay, so underneath the talus, this bone right here, and then underneath it, this big old one, that's the calcaneus right here, calcaneus. Now the calcaneus is basically your heel, and we have a tendon. It's more commonly known as the Achilles tendon, but the correct terminology for it is the calcanean tendon, the calcanean tendon. So the calcaneus is right here. The calcanean tendon wraps around like this and wraps up into, basically connects with your calf muscles. I won't get into the muscles yet. It'll articulate with the calf muscles here. And then it wraps under, and that's where you get like your plantar fascia there too. If avulsion happens of this tendon, oh, it hurts really bad apparently. It rips off. Avulsion is when a tendon rips off of the bone, and then it's supposed to like shrivel up, like as if you were to like pull the curtains and then yank them on up. It's supposed to do that, and it's not supposed to be pleasant. So that's the calcaneus with the calcanean tendon that attaches to it. Next is the navicular. This is another term that is supposed to look like a moon shape. You can kind of see it on the other side, but I always think of like a Navy ship or something like that, of a navicular. So anywho, that one is going to be right next to the talus here. Then we have this grouping of bones right there, the medial cuneiform, intermediate, and the lateral cuneiform. Now, even though the medial cuneiform is the most medial, even though the lateral cuneiform isn't the furthest lateral, it doesn't mean that it still doesn't have its lateral position compared to the medial cuneiform. So it's medial, intermediate, and lateral cuneiform. And then the last one is cuboid. It just has like a cube shape. That's all. I would have a mnemonic for this one, but I never remember it because I don't ever like the one that I find. Something about like tall California Navy boys or something like that. But it never sticks for me. So if you guys come up with a better one, please let me know. I'd love to have another one. Oh, all right. Give me a couple things that you remember from the lower appendicular. Ready, set, go. I know you're burnt out. Give me a couple.
The L in was it fibula is lateral?
There we go. Good. Next.
The patella, the kneecap, the
There we go.
patellar surface.
Patella is the kneecap. Yes, go.
Talus tibia.
Talus tibia for the joint. Love it. Next.
Olecranian for the elbow.
There we go. Yes. And then where does that olecranon go?
In the trochlear notch.
Oh, close. Close, close, close. It has the name in it.
Radial notch.
No. Your olecranon. What's the other name for it? The place that it goes? And it's a shallow depression. When you extend it, it just fits right nicely in there.
Olecranon fossa.
The olecranon fossa. Yeah, there we go. So the olecranon process goes in the olecranon fossa. Good, good, good. But I like those other structures. Those are still fun structures. Next one, go.
Linea aspera line.
There we go. Linea aspera line. What else?
Only the posterior.
Only on the posterior. Yes, I like it. What else? Who else hasn't said anything? Yeah.
Oh.
No, go for it.
Oh, fibula lateral and tibia medial.
There we go. Fibula lateral, tibia medial. What else?
We have greater tubercle and lesser tubercle in the humerus, and then greater trochanter and lesser trochanter in the femur.
Good, good, good. Love it. Who hasn't talked yet? You got to give me something. Come on. I know there's still more cues out there.
Tell a little fib.
Ah, I love it. There we go. Tell a little fib. Yes. Okay, give me one more. Someone who hasn't said anything yet. One more. Oh.
Tarsal.
Some lovers try positions that they can't handle.
Some lovers try positions that they can't handle. Yes, indeed. And Yadira, you were saying something. Hold up. And I think, Gabriel, you were mouthing something. Don't know if you were talking to us. So I want to hear from both of you.
Yeah. I was saying, you can tell from this the scapula that has a spine, so it's facing towards like the back.
There we go. Like it. Yadira, what was yours?
I said the mnemonic.
The mnemonic. Okay. And Carissa, that's who it was. Sorry, she overtalked on you.
That's okay. I was saying tarsals because we walk on tar.
There we go. So those are a ton of little tricks to remember if you're going to walk away from anything. At least you have those little tricks in your back pocket. It is 10 o'clock on the spot. Technically, we're supposed to go another 5 minutes. Why would we do that? So we're going to end it here, okay? I hope you guys have a great night. Do not forget about the quiz. That's in 48 hours. Due by Saturday, 7 p.m. Make sure to do that. It does open tomorrow. I know it's a lot to cover. Go through those individual videos. You can review this video as well later on. If you have any questions, shoot them my way. Thank you for hanging with me. As always, I appreciate seeing you guys and have a great weekend. See you next time.
Thanks, Danny.
Thank you.